Thank you. My name is Vincent Oswald. I'm an emeritus consultant in ENT at James Cook University Hospital in Cleveland, in England. This is my 63rd year in ENT. I started in 1960, and there's a lot about me on the internet if you're interested in knowing more about it. Now, I'd rather introduce our faculty. Brandon Brandon is a laryngeal surgeon specializing in a wide range of laryngeal disease with emphasis on medical and surgical management of voice and swallowing disorders. He completed residency in otolaryngology and head and neck surgery at Stanford University and fellowship at Harvard in Massachusetts General Hospital. He has spearheaded the office-based laryngology practice at the University of Chicago, and his research interests include adjuvant therapy for early clotic cancer and laryngeal dysphagia. Our next speaker is Dr. Benjamin Rubinstein. He's an assistant professor of otolaryngology at Eastern Virginia Medical School in Norfolk, in Virginia. He's a fellowship-trained laryngologist who specializes in airway, voice, and swallowing disorders. His research interests include neurolaryngology and clinical outcomes for laryngeal and airway reconstruction. Dr. Benjamin is an assistant professor of otolaryngology at Eastern Virginia Medical School in Norfolk. He is a fellowship-trained laryngologist, so we look forward to listening to him and his presentation. Now, our third faculty is not an ENT surgeon, but a GI doctor. Her name is Yalini Vigneswaran, and she's an advanced GI and bariatric surgeon at the University of Chicago, where she lays the Center of Esophageal Diseases as a director. Her clinical expertise is in the surgical treatment of esophageal diseases, including GERD, hiatus hernia, and motility disorders. Her research focuses on improving patient outcome through the development and study of innovative surgical treatments for esophageal diseases. Now, next two members of our faculty are, of course, at home, that's in Pune, where this webinar is being hosted from. And it's a joint webinar between University of Chicago, Brandon Baird, and Sachin Gandhi. So Sachin Gandhi's colleague is Nilanjan Bhavnik, and he has more than 10 years of experience in the field of ENT. He's a medical graduate from Miraj in one of the colleges in India, and then he did his postgraduate in Ahmedabad. His area of interest is swallowing, especially neurological dysphagia and the management. He has been invited faculty for numerous national and international conferences, and he hopes to sensitize more and more ENT surgeons and regarding swallowing issues and their management. He has published his work in many national and international journals. And last but not the least, it's Sachin Gandhi, Dr. Gandhi. Dr. Gandhi is well known in India and Indian subcontinent for the lead that he has taken in laryngology in that part of the world. There is no doubt that his department is one of the best anywhere in the world, and I can vouch for that. Although my vouching probably not necessary or not enough, but Royal College of Surgeons of England have approved his department and 3 scholars under his guidance for the last 6 years or so. And the whole hospital receives an accreditation from Royal Corps of Surgeons of England in London. Now, that must say something for his department, because this is the only department outside UK and Ireland to receive such a recognition in the world. That's the only department. So we're really in good hands of Dr. Gandhi to promote education. He's been a founder member, or founder president rather, of LVA, that's Laryngology Voice Association, and Asian um, Laryngology Association as well. And he's been running laser courses and laryngology courses for us number of years very successfully. And the participants come from as far as Middle East and all the surrounding countries, including Far East as well. So there you are. This is our faculty. Now, what we're going to do is go systematically uh, to each one of the speakers to present their topic that have been allocated. And each one has maybe 20 minutes, but I would like to ask our speakers to give more of a personal experience rather than what's available widely on internet and all that. I think we want to know what you think about it, because you're the expert. What is written on the internet is general, but we want to have specific from you. That's how we hope to conduct this webinar. And I would say that keep your talk to a minimum, because there already been questions sent to us from the audience, and would like to be able to answer them, because that's really it's all about. And then I have some questions myself as well by way of panel discussion, but this is how we're going to proceed. So, Brandon, are you ready?
I'm ready.
Okay.
Yes.
Thank you. Thank you, Brandon.
All right, wonderful. Thank you so much for the wonderful introduction, Dr. Oswald. I'm Brandon Baird. I'm at the University of Chicago, as Dr. Oswald mentioned. I'm just very happy to be here. So I'm going to quickly pull up my slides, and then we'll get started. As Dr. Oswald mentioned, we have a number of people here, and so we want to get through everyone. So I will have a relatively quick presentation. I'm going to be briefly discussing LPR as well as the vocal fold granuloma, but specifically as it relates to the incidence and the diagnostic workup for these patients. So getting right into it, the outline for my discussion will be a quick introduction of what GERD is and what LPR is, and then a discussion of what some of the diagnostic criteria looks like, and discussion of the diagnostic, a brief, very kind of 35,000-foot overview of the diagnostic testing for patients that have what's suspected to be LPR. So what is GERD? What is LPR? Let's talk about an introduction. So GERD, it's a multifaceted disease that encompasses and is potentially exacerbated by gastroesophageal reflux. The epidemiology is typically linked to, quote, Western lifestyle, obesity, can be associated in certain cases with H. pylori, but it has multiple definitions, and the definitions are somewhat quite ambiguous. The initial definition that was described is the Montreal definition, which says that GERD is a condition which develops when reflux of stomach contents cause troublesome symptoms and or complications. And that was back in 2006 that was sort of quote unquote defined. There's a Lyons consensus definition as well, which says that GERD is the presence of excess gastroesophageal reflux, esophageal motor perturbations, and increased epithelial permeability that can be associated with reflux. However, a lot of these symptoms that they're describing are not always specific for reflux. For instance, dysmotility can have motor perturbations, or there can be other reasons for epithelial permeability. So the Lyons consensus definition doesn't quite fit the criteria for a definition that we're looking for. And then finally, the Rome 4 definition, which was published in 2016, discusses reflux as a functional syndrome with GERD characteristics. So it's basically symptom-based. However, there are a number of functional symptoms that can mimic GERD without kind of reflux causality. So it's not, it's become somewhat of a different thing for, difficult thing for many people to define. And likewise, LPR has been difficult to define as well. The AAO defined LPR as reflux of stomach contents, basically up to the laryngopharyngeal space. Again, this is not a great all-encompassing nor sensitive or specific way of describing reflux. So we'll get into sort of the ambiguity with regard to diagnosis in a bit. With regard to prevalence and incidence, so the prevalence is variable worldwide. GERD is a worldwide disease. It's reported in all countries pretty much. The prevalence values in some place like China is about 2.5%, and it goes all the way up to 51.2% in Greece. Interestingly, although the prevalence of GERD symptoms is similar among racial groups, it's known that there is some wide variability geographically. Complications of GERD, such as erosive esophagitis, such as esophageal adenocarcinoma, they are more common in actually Caucasian people, particularly those with central obesity. And reflux is increasingly common in young adults, with the greatest incidence seen in people that are 30 to 39. And esophageal adenocarcinoma is being seen in increasing frequency in younger patients as well, patients under 50. The mortality risk is relatively low with GERD. However, GERD does have significant, substantial societal costs. The societal cost of GERD in 2004 to 2005, direct cost in Canada was about 50 million nationally. It's about 30 million pounds, 50 million Canadian dollars, and 33 million euros. In the US, GERD accounted for about 8 million physician visits, 65,000 hospitalizations, and had an estimated 12.3 billion spent on upper endoscopies in the year. And in Japan, the median or the mean cost for GERD patients aged 20 to 59 was about 266 per patient per month in 2014. That was about 2.4 times the mean national healthcare cost. So moving on to symptoms of GERD, as you know, and symptoms of LPR, as you know, LPR has a lot of nonspecific symptoms that come along with it. It can present with globus, discomfort, can present with hoarseness, can present with throat clearing, a bitter taste in the back of the mouth, halitosis. And it's important to get an accurate history for these patients. You want to know what the triggers are. You want to know if there's interventions the patients have tried, and a number of them will try previously. You'll want to also know if there is prior treatment that's been helpful, and whether or not they've actually done an effective job of doing trigger avoidance. A lot of times patients will be placed on a PPI, and it will sort of not work, quote unquote, and it'll be because they're still drinking coffee and they're still eating spicy food and doing all of the things that provoke reflux. So it's important to really get a sense of whether or not the patients have done a good job of trigger management and intervention. I'm going to briefly discuss a couple of patient-reported outcome measures. So for reflux, so the patient-reported outcome measures that were initially defined came along initially in 2001 by Peter Bolofsky. The one that was published at that point was the Reflux Symptom Index. About 9 patient-reported outcome questions. It's a 9-item patient-reported outcome measure, and a score of greater than 13 is considered positive for LPR. However, RSI has a weakness with regard to correlation and prevalence of symptoms, and a lack of consideration of symptoms, throat pain, odynophagia, halitosis. So many have moved away from the RSI to the RSS, the Reflux Symptom Score, which is a 22-item PROM. There's a shorter RSS as well called the RSS-12 that can be used more commonly in a similar way, and that requires a score of greater than 11 to suggest LPR. There's also the reflux, there are also a number of measures for flexible laryngoscopy, the reflux finding score, as well as the reflux sign assessment, which use things such as arytenoid erythema, anterior pillar erythema, pachydermia, hyperplasia, etc., to define reflux, quote unquote, define reflux on laryngoscopy. And we'll get into that in just a second. So let's talk about the diagnostic testing for reflux. So historically, most otolaryngologists define and diagnose reflux in their first visit, their office visit, using flexible laryngoscopy. I put strobe in parentheses because there is a rule if the patient presents with hoarseness of making sure that you also perform a strobe for these patients to rule out any pathology along the medial aspect of the folds. pH impedance testing is considered the gold standard. Barium swallow has also been recommended as well as high-resolution manometry and esophageal gastro duodenoscopy and indicated for patients with reflux. With regard to pH monitoring, I'll just say that there's no study to date really evaluating the prevalence or incidence of LPR with pH monitoring specifically in the general ENT population. However, Dr. Jamie Kaufman, who did a lot of this initial work back in the 80s and 90s, estimated an LPR incidence at about 10% of the general population, the ENT population in an outpatient clinic, and added about 30% of the population that documented acid reflux on their dual pH monitoring. So flexible laryngoscopy, what we're looking at is erythema, post-cricoid edema, intraretinoid pachydermia, which is sort of an intraretinoid hyperplasia or sort of an increased appearance of intraretinoid tissue, pseudosulcus, which is a puffiness underneath the medial aspect of this vocal folds underneath the remiglottitis. However, I do think that there's an important point to be made, and this is for my own sort of anecdotal discussion here. There are a number of studies that have come out over the past 10 years demonstrating that our ability to diagnose reflux with flexible laryngoscopy is somewhat limited and somewhat inconsistent. There are a number of studies that have looked at inter-rater reliability in patients that have reflux findings, specifically using the reflux findings score. And it's demonstrated that the inter-rater reliability between groups of 3 or 10 laryngologists or otolaryngologists is pretty poor. This suggests that our ability to interpret and diagnose reflux, and specifically LPR, is somewhat limited when compared to pH monitoring. And we'll get into this, I'm sure, discussion during our question and answer section. pH impedance testing, it's also known as impedance testing. It's a diagnostic tool that monitors reflux in the esophagus for a given amount of time, typically about 24 hours. The device carries a small acid-sensitive tip that can determine the pH of reflux and its frequency. The measurements, along with the patient's symptoms, can help determine whether or not the patient is suffering from LPR or silent reflux. Historically, it was a long-tubed catheter. It was carried over the patient's shoulder and connects to a recording device that was on the patient's belt. And it went through the nose into the stomach for about 24 hours. So the patient lived kind of their life. We'll get into a little bit more of this, I'm sure, later on with regard to some of the perioperative workup for some of these patients. Historically, or now more recently, Bravo testing, pH testing has been recommended, and that is essentially can be placed during an upper endoscopy. It's a small capsule, and it's temporarily attached to the wall of the esophagus. The capsule, measures the pH levels in the esophagus and transmits the readers to a receiver that's also that's about the size of a pager that's also worn on the belt. The receiver has several buttons on it that you can press when you have symptoms such as heartburn or other reflux symptoms. And you'll given a diary to keep track of your symptoms as well. Barium swallows can help detect reflux as well. There's a low sensitivity with barium swallows. It's important that if you're performing a barium swallow yourself and or you're requiring a barium swallow to be performed by one of your speech and language colleagues, that you have a high enough frames per rate second to assess not only the reflux potential, but also to assess other mimics of reflux like dysmotility and other problems that you might encounter, cricopharyngeal bar, or cricopharyngeal dysphagia. Currently, barium swallow can be performed in clinic, can be done along with a C-arm, and it can be done pretty easily as part of your general evaluation if you have a radiology suite. High-resolution manometry can also be helpful to delineate reflux from other similar pathology. If the barium swallow shows any evidence of mild dysmotility, high-resolution manometry can help to better delineate and better characterize that. Manometry tests sense the pressure of the constriction of muscles in the esophagus as you swallow. It can detect patterns of muscle activity throughout the length of the esophagus. And it can indicate whether or not contractions are too weak or too powerful. The barium swallow can't measure the strength of the muscle contractions. Again, it utilizes a nasal gastric probe. It can be performed in the office as a sort of a supplement to your normal diagnostic workup. And patients are administered small food boluses that allows us to sort of see how well their esophagus is contracting and squeezing and whether or not there is any issues that the patient might be having. And then finally, I'll just briefly talk about EGD. And so it's a great evaluation of the esophagus, and specifically an evaluation of the internal lining, the lumen of the esophagus. It should be performed on patients that have long-standing reflux as a screening tool for Barrett's and/or esophageal adenocarcinoma. One of the nice things about our field is because we do so much office-based laryngoscopy and endoscopy, there are office-based approaches to esophagoscopy, specifically with a transnasal esophagoscope. This can be performed in clinic and can be a quick and dirty screening method for patients that have any degree of abnormality. You can also screen for other pathology that may be associated with reflux, such as eosinophilic esophagitis, and can be also paired in conjunction with a FEES study to look for other dysphagia or causes for dysphagia. There are some limitations in the reflux evaluation using EGD because you're not necessarily always seeing reflux with your EGD. So that's pretty much it for me. I know that we're trying to keep it short and sweet, so I'll end there. I'll open up the floor for others to kind of to do their thing. Thank you, though.
Thank you, Brandon. I think we come next to Dr. Pavnik, who is going to tell us about the all-important condition in children and infants. Let's hear from him. Thank you. I think you're muted.
Very good evening.
Thank you.
Thank you very much, sir. And I think I'll just share my screen. Okay. So I'll be speaking on pediatric laryngopharyngeal reflux. Now, we all know that laryngopharyngeal reflux is defined as the retrograde flow of either the gastric acid or contents of the stomach into the larynx or into the pharynx. Now, for a very long time, it was considered as an extension of GERD, but then there are some important points which need to be highlighted and remembered. That is, GERD is usually a problem of the lower esophageal sphincter, whereas laryngopharyngeal reflux is considered a problem or an issue with the upper esophageal sphincter. More importantly, studies have shown that the esophagus is designed to withstand reflux and acid even 50 times a day, but then even a single incident of reflux into the pharynx or larynx can cause injuries. So laryngopharyngeal reflux in that sense is quite a different pathology from GERD as we know it. Now, there's no widespread epidemiological data for children, but then based on estimates of adults and overall symptomatology and experiences, it's been surmised that approximately 20% of children suffer from reflux disease. Now, this does not necessarily mean laryngopharyngeal reflux. This also includes GERD. Now, the contents of reflux, the gastric reflux, are gastric acid, pepsin, bile, trypsin, sometimes gases. Now, what's important or worthwhile to remember is it's pepsin rather than the gastric acid, which is the bigger culprit in causing all the injuries in the laryngopharyngeal region. We'll come to that shortly. Now, there are some gaps in the literature as well as in our knowledge as to especially pediatric LPR. First of all, it's difficult to differentiate LPR from GERD in very young children. The reason being that in children less than 1 year of age, gastroesophageal reflux also has a lot of extraesophageal manifestations. A lot of it is considered physiological. So difficult, it's really very difficult to diagnose LPR in very young children. Again, there's hardly any gold standard for diagnosing LPR in pediatrics. So that, again, is a second lacuna in literature. And finally, what's important is scientific evidence is yet not conclusive about what sort of management strategies need to be adopted for children. Now, it's pretty well known that infants are quite prone to reflux. In fact, a lot of these infants have reflux, which is called physiological LPR, up to the age of 1 year. A lot of these children have regurgitations. Not all of them necessarily have lasting symptoms. Usually, the peak episodes are around the age of 4 to 6 months. What happens usually after that is the infants are started on solid feeds and the reflux episodes start reducing, usually resolved by the end of a year. Now, more often than not, the reflux presents as airway problems, sometimes gastrointestinal problems, and they can be, undiagnosed just because these children keep on getting treated for airway problems, allergies, and the underlying reflux might just get missed. But then what is also true is that since a lot of these children just outgrow these reflux problems after a year, it's usually not important. But then a high degree of suspicion needs to be maintained. Now, with an increasing incidence of childhood obesity, it's surmised that probably the incidence of LPR has also increased over the last few years. Now, there's a reason why children, or especially infants, have a higher incidence of laryngopharyngeal reflux. Probably the first and most important reason is the immaturity of the esophageal sphincters. Now, studies have shown that the lower esophageal sphincter keeps on maturing till the age of 2 years, and probably even more. Again, for the upper esophageal sphincter, there are very limited studies, but what's been shown is that the upper esophageal sphincter in infants is considerably different. The pressures are considerably different from that in adults. So, and they keep on maturing. So the immaturity of the sphincters is probably one of the first reasons why LPR occurs more commonly in younger children. And of course, their milk-based diet is a very big cause too. Their position, which is usually recumbent, that promotes LPR. So newborns usually have an esophagus which is around 8 to 10 centimeters in length. As they grow bigger, up till the age of 15 years, it becomes approximately 19 centimeters. So shorter esophagus causes easy reflux into the larynx and the pharynx. And finally, the angle of His, the gastroesophageal junction, the acute angle, that has been conclusively shown that especially in children having laryngopharyngeal reflux, gastroesophageal reflux, is more of an obtuse angle rather than an acute angle. So these in total form the sum total of reasons why infants suffer more from laryngopharyngeal reflux. Now, it's as I was mentioning earlier, pepsin is usually the bigger culprit as compared to acid for causing the injuries. Now, in infants, it has been seen that most of the reflux episodes are weakly acidic, which have a pH of roughly 4 to 7, or non-acidic, which is pH of greater than 7. But then pepsin, it gets activated at a pH of 4, and it stays active up to a pH of 6.5. Even after that, it maintains its stable state, and then again can get reactivated when there's an acidic reflux into the pharynx. So this is very important. Now, these refluxes, both pepsin as well as acid, cause mucosal trauma and swelling. As a result of the mucosal trauma, there is inflammation, there is mucus hypersecretion. The cilia in the pharynx and in the airway tend to start dysfunctioning as the pH goes lesser than 5. Also, because of the pepsin, it says that the connections between the cilia tend to get broken. As a result of this, there is ciliary dyskinesia, there is increased collection of mucus and secretions which cannot be cleared very well. Again, there is higher expression of inflammatory mediators. Carbonic anhydrous 3 is one of the enzymes which is important for preventing acid injuries. It promotes alkalinization of the laryngopharynx region. But then there's reduced expression of this because of pepsin. This causes or promotes injury in the laryngopharynx. And finally, there is a pathophysiology or a thought process which says that even higher gastric content, or rather acid in the lower esophagus, promotes vogal reflexes and causes increased cough, which starts from the bronchial end. The vagus is probably responsible for this reflex. So this is another mechanism of the symptomatologies that occur in a reflux. As I was mentioning earlier, there are 20% of children or rather infants can have LPR, but then this incidence or this increases dramatically with these conditions: hiatal hernia, eosinophilic esophagitis, achalasia. All of these, it's been seen that the incidence of GERD at least increases to nearly 70%. So a high degree of suspicion is warranted for these conditions and consequent LPR. Now, this is, of course, Belafsky's reflux symptom index, which Brandon was talking about. This has not been standardized for the pediatric population. But then what's important out here is probably difficulty in swallowing food, liquid, pills, coughing after the children have eaten and are lying down, choking episodes. All of these are probably indicators of a possible reflux problem. Now, as of now, there is no symptom index which has been standardized for the kids, but then this is something which needs to be taken into account, and some of these symptoms probably are part of the symptomatologies of the pediatric population too. So the investigations again for the pediatric population: laryngopharyngoscopy, 24-hour pH monitoring, salivary pepsin measurements, and MRI pH. I'll just be talking about laryngopharyngoscopy in a little while. Prior to that, 24-hour pH monitoring, especially of the esophagus. The problem with that is it detects pH or acid refluxes only. Now, pH less than 4 is what is detected. The problem, as I was mentioning earlier, is that a lot of these infants, a lot of these kids have refluxes which are weakly acidic or sometimes even non-acidic. The pepsin refluxes, these are not noticed on a pH monitoring. Also of late, what's being started is a monitoring of the pH of the oropharynx, which I'll be talking about in a little while. The salivary pepsin measurements is something which is coming into the fore. So measuring the this is probably one of the best non-invasive tools and can be implemented for children. It's not yet so. But then for adults, it's being seen that a cutoff score of having 216 nanograms per ml of pepsin in the saliva is probably highly indicated of LPR. So that is something which is future direction probably for children, and probably children can a non-invasive tool wherein children can be diagnosed to have LPR just on the basis of this. Now, multi-channel infraluminal impedance with pH monitoring is considered the gold standard for diagnosing LPR. And the problem with that is, one, the cost, the probable required hospitalization, especially in children, and the difficulty in inserting the catheter and keeping it inside. So we'll come to that in a minute. Prior to that, let's discuss endoscopy. So this is the reflux finding score, which is a very valid score for adults, but then not so validated, yes, for children. But among these, what's being seen is that the erythema over the arytenoids or hyperemia of the arytenoids, vocal fold edema, and diffuse laryngeal edema are one of the most common findings that you note on endoscopy for children suffering from LPR. This here is a video of a child who's being treated for laryngopharyngeal reflux and GERD for a very long time. I urge you to have a look at the vocal cords and the arytenoids. Funnily enough, nothing much out there. Which brings us to the next point: extralaryngeal endoscopic findings. So what's been seen on studies, and probably this is one of the best studies that have denoted it, is that endoscopy, especially with a narrowband imaging, have findings other than laryngeal findings, which are quite diagnostic or depictive of LPR. Lingual or tonsil swelling, pharyngeal pillar inflammation, hypopharyngeal cobblestoning, coated tongue, tracheal inflammation, or sometimes even narrowing of the trachea. On the basis of this, let's just go back to this previous video and have a look. What you'll notice is a lot of cortex turning of the postpharyngeal wall and the hypopharynx. So this is what needs to be kept in mind when we are doing endoscopies for the pediatric population. You may not find the exact findings that are depicted on the reflex finding score. There are extralaryngeal findings too, which need to be taken note of. So as I was mentioning, the intraluminal impedance with pH monitoring, the advantage is that it detects not only acidic, but the weakening acidic as well as non-acidic reflux too. Also, additionally, it detects the gaseous and mixed liquid and gas mixed reflux comes up. That is detected too. So this is probably one of the best tools for adults. The problem in children, as I was mentioning earlier, is the insertion itself, then the keeping it for a duration of time. Usually hospitalization is required. And so presently there are very limited studies which have done MII-PH on children. Again, as I was mentioning earlier, oropharyngeal pH monitoring and Ryan scoring of the same. Now, this is where we mention or rather measure just the pH of the oropharynx. See, as every time it falls below the pH threshold, which is usually taken to be 4, the number of episodes in which the pH drops below threshold, the duration of the longest episode, all of these components then are calculated based on the machine software and a composite Ryan score, which is what is considered normal as a below 9.41 in the upright position, and considering that saliva is secreted less during sleep, so below 6.8 in the supine position. There are some conditions which are associated with LPR, and studies have shown each of these conditions have some sort of association with LPR. Subglottic stenosis, laryngomalacia, recurrent respiratory papillomatosis, aspiration of pause, chronic sinusitis, adenoids, asthma, even otitis media. What happens is, for prevention of aspiration, the supraglottic mucosa must be able to sense that there's a food bolus coming. This mechanism gets deranged or disrupted when there is edema because of the constant gastric aspiration. This causes decreased sensation and consequent higher rates of aspiration in children suffering from LPR. Coming to laryngomalacia, there's a very strong correlation between laryngomalacia and reflux, meaning that there is a very high proportion of patients or children having severe laryngomalacia, and they also have reflux. The question is whether one causes the other. Right? There's no scientific evidence as to that. So it's also been seen that if reflux is treated, some symptoms of laryngomalacia like coughing, choking reduces up to a large extent. But then whether supraglottoplasty has reduced reflux, right? No scientific evidence as to that. But then supraglottoplasty does improve aspiration. That is what has been seen, especially in severe laryngomalacia groups. Coming to subglottic stenosis. Subglottic stenosis and laryngomalacia also have a high degree of correlation. The irritation and the mucosal damage because of the acid pepsin begins the stenosis process. Then the reflux itself prevents the equilibration. There's downregulation of EGF, and this EGF downregulation also reduces the mucosal turnover. And all of this in combination increases fibroblast differentiation and, as a result, stenosis. So there's a high degree of correlation between subglottic stenosis and LPR. It will be good to note that whenever we do get to see a subglottic stenosis patient, the child needs to be monitored or investigated for LPR too. I'm not going into a lot of detail for recurrent respiratory papillomatosis. Safe to say that increased sensitivity because of the LPR may worsen presentations of these diseases. and also may increase frequency of surgical debridements, and at least that is what has been seen on scientific literature so far. Also, treatment for these may reduce soft tissue scarring, which is one of the dreaded complications of RRPs, and also the incidence of laryngeal breaks. Again, adenoid hypertrophy and LPR has shown a high degree of correlation with pepsin being detected in a very large proportion of children with hypertrophic adenoids. So coming to management of therapies, for a very long time, H2 receptor antagonists were the mainstay of treatment, and following that, PPIs too. The proton pump inhibitors, because of the longer duration of action, have taken over, and H2 receptor antagonists are in the background now. But then we must just remember that the children usually have more of mildly acidic and non-acidic reflux. So what do PPIs do? They reduce the acidity overall in the reflux. That may not necessarily help the child. In fact, it may worsen the reflux injury because gastric acid has a pH of approximately 1.5 to 2. And if we reduce, and it comes down to say 4 or even 5, pepsin gets activated and it stays activated. So injuries due to pepsin may worsen with PPIs, and that is something that needs to be kept in mind. So the distinction that needs to be made is that whether there's an acidic reflux.
Sorry, Bhavnik, can I interrupt? Your
Yes.
time is up. Please
Yes.
wrap up, please.
I'm done. This is the last slide, actually. So use of alginates probably is a more preferable alternative, as they form a layer and a protective layer for the gastric mucosa. Diet changes like breastfeeding the child more, which reduces reflux. Then lifestyle changes, as in keeping a gap between sleep as well as the meal times. All of these have helped in improving reflux. Surgical intervention, as and when necessary, especially for hiatus hernia, is probably the go forward when we have conditions such as that. I think I'll wrap up here. Thank you very much for hearing me.
But Dr. Oswald, you're muted, I believe.
Yeah. Can you hear me now? Yeah. Thank you, Benjamin. We go to Benjamin Rubinstein, who is going to tell us about the management. Thank you.
All right, great. Thank you. So I'm Dr. Ben Rubinstein. Thank you for having me. It's a pleasure to be able to participate in this grand rounds. It's the morning here for me, 7:30 a.m. And I live in Norfolk, Virginia. We're right on Virginia Beach. It's a lovely place to live. I'm in a nice academic department. We have 3, now 4 residents a year, and I really enjoy this topic. I think one of my favorite things about giving these types of lectures is I always learn something when I'm preparing the lecture, and then I'm seeing my patients, 2-3 weeks before the talk and thinking about them more critically. So thanks again for having me. So the pathophysiology you just heard about very nicely from the pediatric perspective, and it's similar in adults. Acid exposure at the larynx, even in small doses, can cause damage. Dr. Bach, who is one of the excellent researchers in the United States on LPR, defines one event of pH less than 4 at the pharyngeal monitor on pH impedance testing or greater than 40 proximal impedance events without acid as diagnostic of LPR. And I think that's appropriate. Because really we shouldn't be having reflux into the pharynx of such a low pH, because there is a protective effect of the salivary bicarbonate to protect against the elevation of or the acidification of the pharynx. We see that, in our patients who do not have saliva, they've had radiation, they have different causes of xerostomia, they're at higher risk because they're not neutralizing the acid, either in the esophagus or in the pharynx as well. And so I do keep that in mind for my patients. Pepsin is important. You can biopsy, that's more experimental, but salivary levels are coming into play for clinical testing. Activated pepsin, we talked about, less than pH of 6 may be relevant. But even inactive pepsin may cause cellular changes at the larynx. There was a nice study by Dr. Bach's team where they saw that carcinogenic gene expression in cell culture was altered and microRNA expression in cells that were exposed to pepsin, even in the inactive form. So it may be relevant to disease process such as carcinoma or hypercellular disease of the larynx. The pepsin in the pharynx does appear to disappear after fundoplication, suggesting that it truly is coming from a reflux event. The laryngopharynx is more sensitive to acid and pepsid exposure, as you've heard. So this is what we have. Hopefully you can see the flow chart. This is from Ford in 2005, and this is the most recent flow chart for treatment of LPR in the adult. And I'll just start by saying, when you define LPR as a disease entity by symptoms, it's very complicated to know that you're really treating reflux. And so, and as you've heard from Dr. Baird as well, the reflux finding score is fraught with being non-specific for LPR. The reflux symptom index may be a little bit better. The reflux symptom score may be even a little bit better than that. So here we have the initial assessment. You think that a patient has LPR, you do RSI, they fill out the questionnaire, you look at their larynx, because you always must look at the larynx to ensure that you're not treating a different process. I think this is one of the most important things that we can share with our colleagues in general internal medicine and even GI. When patients are having throat symptoms, they should have a scope exam from us. And then an empiric therapeutic trial. So what Dr. Ford recommended was lifestyle diet modification and PPI for 3 months. And then we reassess. Are their symptoms resolved? If so, titrate their PPI, ideally off. If their symptoms are improved, but not gone, increase the PPI. And then if symptoms are unchanged, look further for reflux with testing, impedance, pH monitoring, TNE, EGD, manometry, barium swallow. So this is all good and well, but we have to remember 3-month follow-up assessment, 3 months have passed. A lot can happen in 3 months. Viral laryngitis can resolve. All sorts of different problems can resolve themselves in 3 months. You don't necessarily know, is it the diet and lifestyle modification or the PPI, if we're just taking a large group of patients and we're treating them all empirically. And then if the symptoms improve, increasing the PPI, I'm not sure. That's not necessarily my practice personally. So moving on, what about silent reflux? I don't know, everybody can have their own opinion in the audience today and in the panel. Do you like the term silent reflux? I don't like the term silent reflux. And I'll tell you why, because my patients come in and they say, I don't have any reflux symptoms. I don't have any heartburn, I don't have anything. But, the physician or the nurse practitioner that I'm seeing, they say I have silent reflux. And that's the real cause of my problems. So it's not silent reflux if they have symptoms. That's my opinion. If they have globus, if they have dysphagia, it's not silent reflux. They have reflux that's causing a problem. If we can determine that the reflux is really the etiology of their disease process. And so the idea of silent reflux, I just don't really like that, because I think that patients always have some symptom that they're coming for. You know, I think that all of my true LPR patients have some GI symptoms. I rarely find that the patient that, you know, that comes to me, they just have one symptom and they have no GI issues at all. I ask them all of these questions. Do you have postprandial belching? Do you have bloating, early satiety, postprandial excess mucus, regurgitation, globus during your swallow, supine globus or excess mucus, heartburn, indigestion, food intolerances, dysphagia? Do they have a history of dysmotility? Often, my LPR patients have a history of heartburn or any of these above symptoms before, but then they sort of got better, either because they took a medicine, maybe they changed their diet a little bit, but often you can identify some GI symptoms in LPR patients. That's my belief. Because there are a lot of other conditions that cross over with throat issues, right? Laryngeal hypersensitivity, is that LPR? No, it's not LPR. It's a neurogenic problem. It can be from a vocal cord paresis, a laryngeal neuropathy. It can be from all sorts of different things. Does GERD potentiate the disease process? Sure. If you see neural injury in the middle of the slide, chemical irritants, airway inflammation, or oxidative stress, those can lead to inflammation that may cause a hypersensitive throat. But then this hypersensitive throat becomes its own issue, right? So you have local neuropathy with throat clearing, globus, a tickle sensation in the throat. And then, you know, people are coughing even to an innocuous stimulus like cold air or smoke or perfume or something that, you know, shouldn't cause them to cough. They cough anyway, often for extended periods of time. It's not because they're having reflux events constantly throughout the day, but maybe the reflux set this into motion a little bit in some patients, sure. Now, there are patients that just have reflux, they cough, and then, you know, they're kind of a different story because they don't typically have this urge to cough and innocuous stimulus cycle that occurs. So again, in my mind, the problems with empiric treatment, you hear people saying these things like, the LPR patients who do not symptomatically improve with anti-reflux therapy often have another underlying laryngeal disorder, such as a vocal cord paresis. Okay, we can diagnose a vocal cord paresis up front. We don't need to treat them empirically for reflux to find out that they don't have it. That's how my practice goes. And I'll mention that, you know, as a fellowship-trained laryngologist at a tertiary academic referral center, I don't see a lot of the patients that get better with time or PPI, because those patients are getting treated by my referring physicians. And so my practice is a little bit skewed, right? Because those patients that they just have reflux, they get treated, they're, oh my gosh, doc, I'm so happy you fixed me. I'm not seeing those patients quite as often, only when the primary care doctor sends them directly to me. And so what we know is that, you know, this is another one of John Bach's studies. When you look at a group of patients that he, you know, in his department, they think, okay, this patient has LPR. What percentage of them are going to have positive dual pH impedance probe testing? 40% are negative studies. So they think that these patients have LPR, they're wrong. You know, only 46% met their criteria, and then they had some equivocal patients. Who are these patients? Patients with throat clearing, cough, sinus, heartburn, globus, subglottic stenosis is in decreasing frequency. You can see on the pie chart. And then you can see in results by indication, the little bar graph, that, you know, 63% of their heartburn patients, 63% of their globus patients, 52% of the cough, only 50% of their subglottic stenosis patients ended up having positive testing. The throat pain patients they suspect are mostly musculoskeletal issues. Dysphagia, pretty high percentage, 50%, and 50% equivocal. So the dysphagia patients, you would say almost 100%, negative, which is kind of interesting in their group. So let's say it is reflux. What do we do? Treatment options, non-surgical. I like to start here if I can. Diet and lifestyle modification has been shown to be extremely effective. And we also have acid neutralizers, reflux blockade, acid suppression, or some combination. So treatment, empiric diet modification, that Mediterranean 90% plant-based diet with alkaline water is what I recommend my patients to start with to keep it simple, as well as reflux precautions. Zalvin did a retrospective cohort study of his LPR patients, basically gave everybody PPIs for a bunch of years, and then he's like, oh, I'm not going to do that anymore. I'm going to give them this Mediterranean plant-based diet. And he saw that the RSI reduction in his patients was non-inferior to the PPI with reflux precautions. So he's a strong advocate for that now. And I think it was, it's a reasonable study to consider. Identification of causes of distension. So I really like to ask my patients, what happens when you eat lactose? Because if you're lactose intolerant and you get super bloated after eating lactose, you're going to have reflux. At least you're going to be predisposed to reflux. I ask about specific food sensitivities. Gluten sensitivity can be relevant. Fiber supplementation has come into play, I think, for functional medicine, right? Trying to supplement prebiotic fiber to improve the microbiota of the stomach. Avoidance of alcohol, especially wine, which is very acidic, red wine. Avoidance of caffeine. Both of these can relax the lower esophageal sphincter. Avoidance of carbonated beverages, greasy, spicy foods, acidic foods. You can also, if people really want a lot of guidance, you can direct them to Dr. Aviv's Acid Watchers book or his website. And they give very specific instructions about how to neutralize acid in the foods people want to eat, still be able to enjoy, a very comprehensive diet, and also, foods that they should specifically avoid. More on diet, lifestyle modification, food portions. Avoid eating close to bedtime is a big one for LPR patients. Avoid exercise on a full stomach, weight loss, and then head of bed elevation. Alginates have become very strongly part of my practice. They block acid by forming a raft in the stomach at the GE junction when exposed to acid. So they block acid and non-acid reflux. Typically, the alginate will also have some sort of acid neutralizer mixed in with it, bicarb. And Gaviscon Advance has been shown to be as effective as omeprazole in non-erosive reflux symptom control. There's a variety of different brands available. There's this interesting study where they took esophageal mucosa, esophageal cell culture model, and they exposed the cells to pepsin and acid solution. And what they saw was that, in fact, compared to sham or placebo, sham being saline, placebo being like a viscous solution, the Gaviscon Advance and the Gaviscon Double Action, which are shown below, actually preserved the gap junctions. They preserved the epithelial disruption and prevented that barrier disruption. And they suggest that, they think it's the alginate that's actually doing this because they washed the Gaviscon off of the tissues. Now, it could have been the neutralizing substance as well, meaning the base. But interesting to, I tell some of my patients, it actually coats your throat, the alginate. Here's a few pictures. PPIs are very effective in many patients. Daily or BID dosing, we stress that patients take it 30 minutes before meals. And then we have famotidine as another option, sometimes higher doses, especially if they have esophagitis. the PPI. So you just want to make sure that you define your treatment success very clearly. Some advocate for up to 6 months of therapy to allow laryngeal healing. Some suggest that tissue healing can progress even to up to 4 to 12 months after fundoplication. But you do want to titrate the dose down and wean off after treatment success. It's not uncommon as you're weaning off for patients to have a little rebound because of the prior receptor blockade. And so we counsel them on using diet and alginates and H2 blockers to get through that. Be careful with PPIs because they can have drug interactions. Plavix, there's a suggestion that it may make Plavix half as effective by inhibiting the cytochrome system. Warfarin, PPI can enhance the effect of warfarin, increasing bleeding. The basic environment of the stomach from the PPI could reduce bioavailability of medications. And there's suggestion that diazepam could be potentiated as well, reduce clearance. Other precautions. This is very much in the media, right? Patients are thinking about it. My kidneys, my heart, my dementia risk. So there are a variety of adverse effects that have been associated with PPI use. B12 malabsorption, C. diff infection, pneumonia potentially due to alteration of the microbiome of the stomach. Gastric cancer may be more common with chronic high-dose PPI use, and a variety of other conditions that you see on the list there. When you should wean the PPI, unless there's a strong indication for PPI. Refractory gastroesophageal reflux disease, Barrett's esophagus, etc. Transition to diet and lifestyle modifications. The other consideration around PPI, they have separate antioxidant properties and direct effects on neutrophils that may prevent inflammation. So still, the response to a PPI is not necessarily proof that you're treating acid peptic disorder. It's proof that you're treating at least inflammation, maybe inflammation caused by the acid. There's a variety of complications of reflux that have been suggested over the years, and you heard about some of them from our previous speaker on the pediatric population. Cough is one, but what we do, I think, know pretty solidly is that a PPI is not indicated with somebody who has chronic cough who doesn't have heartburn. But that doesn't mean you can't recommend diet modifications or even test them for reflux with pH impedance testing. Dysphagia, frequently with globus, is common with these reflux patients, but those patients need an MBS. They need a barium esophagram. They might need an EGD if they have solids, especially liquid dysphagia. But I do see a variety of patients, they come in, they have esophageal dysmotility, and they take reflux medicine, they get better. Laryngeal edema and inflammation, it's important to rule out other etiologies. It could be reflux. Idiopathic subglottic stenosis. We see, in studies, maybe 50% of the subglottic stenosis patients have positive pH impedance testing. And we've seen that PPI use and endoscopic dilation does not affect the interdilational interval. So is there a link? It's not clear at this time. And then laryngeal cancer and other inflammatory diseases of the upper airway. I'll finish with just a couple of photos. This is a patient that I saw this week who has idiopathic subglottic stenosis. You can see she has some, interarytenoid thickening of pachydermia. She has almost like a pre-granulomatous ulceration of the medial surface of the arytenoids. Perhaps a little pseudosulcus on the left. I mean, that scar on the right, where the stenosis is getting close to her conus there. And, she's drinking a glass of red wine every night. But she says, I have no reflux. So how far do I need to push her to get her to address reflux? It's not clear, and where I live, a lot of patients, they don't want to have a probe in their nose for 24 hours. So I do have patients, though. This is another patient. This is the same patient on the left. This is a rigid exam. And then on the right, a different patient who had a fundoplication because she had Barrett's as well as idiopathic subglottic stenosis. She still has those little changes to the medial arytenoid, but is her larynx less inflamed? Just from looking at it, we can't necessarily tell. She's had treatment for many more years than the other subglottic stenosis patients. So my takeaways: LPR injuries through pepsin acid exposure can cause cell injury. There's lots of ways to protect against that. Diagnosis by symptom alone is prone to error. In my experience, patients tend to have some GI specific complaints when reflux is deriving their symptoms. Diet, lifestyle modification are essential and without complication. So I like to start there, but twice daily PPI can be effective in patients who require acid reduction. And the evidence for complications of reflux is an area for further study, certainly. Thank you for your time.
You did? Thank you, Ben. It's been very useful. I think the point I took from your presentation is you do have to consider the age of the patient, and particularly in the elderly. You have comorbidity and there's an interaction of drugs with their own conditions. Thank you. I think next one is Sachin Gandhi.
Yeah.
With arytenoid granuloma. Of course, not a common condition, but in India being a very huge population, you get all sorts of conditions presented to you in a short space of time. Thank you, Sachin.
Yeah. Thank you, sir. We just go along this common condition we see in our clinics, and with increased incidence in last few years, with patient coming with non-specific complaints, as we see pricking sensation in the throat, pain in the neck, and then you do the scopy and we find this granuloma, and there is a question what to do for these granulomas. In a short, what is the arytenoid granuloma? So as the name suggests, it's a granuloma or the inflammatory reaction over the arytenoids, and that's because of the perichondritis due to some reason or the not. So it is benign, exophytic inflammatory lesion that may arise or that arises either from the vocal process or it can arise from the body of the arytenoid. It could be unilateral, bilateral, generally seen in 4th to 5th decades of life. As we go along, and so is the history, the publications was first described as an entity, contact ulcer of the larynx by Chevalier Jackson because of maybe reflux or chronic irritation because of vocal strain. But it started with contact ulcer, and then many terminologies were introduced to describe this lesion, like contact ulcer, contact granuloma, vocal fold granuloma, post-intubation granuloma, vocal process granuloma. So many people describe this entity as per the etiology or the appearance. Either it can be pedunculated or it can be sessile. Most of the cases, it would be a sessile lesion. What are the factors we know of which produce arytenoid granuloma? Laryngopharyngeal reflux again is the commonest. It could be symptomatic or silent. There could be other irritants like post-nasal drip, allergy. Again, smoking may play a role due to its allergy, irritation of the arytenoid and the perichondrium. Another commonest which we see is a traumatic. Most of them because of the intubation, either an emergency intubation or prolonged intubation with neurological condition and admission in the intensive care unit. In surgeries we do, especially in which we encroach upon the cartilages, like we do partial arytenotomy for bilateral palsy, then we are going to cut through the arytenoid cartilage, which is going to produce, may produce
a granuloma as an inflammatory reaction or reactionary granuloma. It could be because of chordectomies for early glottic CA when we resect into the thyroid cartilage or cricoid cartilage during the airway surgery, and the granulomas may come over as a reactionary granulomas. These are known because of the blunt neck trauma and again hyperadduction or the trauma to the arytenoid cartilages nearby. Another factor which we should remember is vocal abuse or hyperadduction compensatory mechanism in cases of glottic insufficiency, like we see in unilateral vocal cord palsy or sulcus vocalis. So there is a hyperadduction, and because of the contact, strong contact of the arytenoids, there is a reactionary granuloma, inflammatory granuloma. Again, in post-operative patients of laryngeal surgery. Any of these in which you can't find a cause, again, some series published says most of them are idiopathic. When you see a granuloma over the arytenoid clinically, you have to rule out inflammatory or pyogenic granulomas, tuberculosis, again in India or this part of the world. I have seen pleomorphic adenoma, amyloidosis, few cases, mild, moderate, severe dysplasia, and again squamous cell carcinoma. You have to rule out when you see persistent granulomas in the arytenoids. As we see and grade them, when they are limited to the vocal process, as classified by Farewell, this would be grade 1 unilateral, so A. Grade 2 would be limited to the vocal process, but ulcerated. Grade 3 again big enough, extending beyond the vocal process, but not crossing the midline. If they cross the midline, again grade 4. And any of these, when they become bilateral, it becomes B status. So 1A, 1, 2B, 2B, 3B, or 4B. So this is a 4B status. Wang et al. Actually again said when it's limited to vocal process, grade 1, extending beyond, again going into the up to the first chord T. We have learned about this pathophysiology due to LPR, again inflammation because of the laryngopharyngeal reflux. Intervention going into the posterior glottis, again ulcerates or traumatize the arytenoid, perichondritis and granuloma formation. Vocal abuse and chronic cough, similar irritants, similar trauma and production or development of the arytenoid granulomas. The histopathology, hyperplasia, edema with chronic infiltration. You have to always remember there is always neovascularization. How clinically it affects, because when you cut through the granulomas, there is going to be local bleeding, which you should be aware of and put in guidelines of neuropathy while you are cutting through the arytenoid granulomas. Clinical symptoms, we have already gone through this, but fullness, fullness after meals and neck pain on the same side of the granuloma again indicates there is something into the arytenoids or the larynx, and granuloma may have been there. Signs would be again thick endolaryngeal mucus, the classical interarytenoid pachydermia or the band, and congestion over the false cords posterior glottis. Because of the trauma, because of the intubation, you can see granulomas like this. They could be bilateral. The treatment of choice in traumatic granulomas would be again antibiotics, non-hormonal anti-inflammatory agents, intralesional and inhalational steroids. So again, anti-inflammatory agent, but if they are because of trauma, this would be the first line of treatment. Hyperfunctional granulomas, commonest we see in cases of glottic insufficiency because of the unilateral vocal cord palsy, which is long-standing, sulcus vocalis. So there is always going to be a contact granuloma on the opposite side. The surgical options would, the treatment modalities we apply is anti-reflux therapy, which already has been described. Commonest adjuvant to the anti-reflux therapy is the speech and language therapy or the voice therapy to the patients to take care of vocal abuse or vocal strain. Steroids, either it could be oral steroids, inhalational, or intralesional steroids. Zinc sulfate is known to help repair of the wounds, the inflammation, can help. Botox locally given can reduce the hyperadduction or excessive muscle strength and can help in resolving the granulomas. The failure of conservative would lead to surgical excision. We have already seen PPIs, H2 receptor blockers, combination with speech and language therapy, lifestyle modification. If this failed, then we can go into the surgical management. Fundoplication is the surgical method of choice if we fail the anti-reflux therapy and we are sure about the origin of the arachnoid granuloma to be the reflux disease. Now, when you decide to go for surgical intervention, again, the medical line of treatment would be for 6 to 9 months. If it fails, or on repeated endoscopy or follow-up endoscopy, you see there is increase in size of the granulomas, then maybe you'll have to go in for surgical management. Airway obstruction would be another indication. A short history, patient is saying it had just come up in last 15 days, 3 or 4 weeks of time, and there is a rapid increase in size. On examination, you see or NBI or eye scan the features of malignancy, or there is a diagnostic doubt whether it is malignant or not. History of alcohol or any tobacco use, smoking, loss of mucosal waves on the stroboscopy. Now see, this is arachnoid granuloma. Now, so you can very well see the mucosal waves, and then maybe you can assure the patient there are less chances of it to be a malignant lesion. What are the different methods you use? Again, cold steel or lasers, CO2 laser, KTP laser, or you can use another method to take a biopsy, office-based TNE guided excision. This is a picture of NBI done on endoscopy. CO2 laser is preferred amongst all the lasers because of its advantage of decreased thermal damage and precise cutting. Now, this is a arachnoid granuloma or a granuloma over the vocal process. Now, these are the points which I have blocked with a scanner mode to reduce bleeding during the surgery. There is always a bleeding, and you have to take care of either with a pack or you block them with a scanner mode of the CO2 laser. This is an OPD procedure through the TNE. To reduce the recurrence, what you can do? You can limit the excessive vocal cord tension with the help of Botox. You can use the Botox when you surgically remove the disease or remove the lesion. Now, what are the points where you inject the Botox? These 4 points have been described. One is thyroarytenoid muscle. Second is the lateral cricoarytenoid. Third is interarytenoid. And fourth is on the aryathletic fold just anterior to the uniform cartilage. So I have excised the granuloma, and now so this is lateral cricoarytenoid. This is the interarytenoid area. This is on the opposite side. And this is anterior to the cuneiform cartilage. You can give intralesional steroid again to reduce the chances of recurrence. You can apply fibrin glue to allow proper healing. This is a fibrin glue actually after the excision. LPR and laryngeal cancer. Now, as William has already described, this association of reflux disease and carcinoma has long been noted, accepted also when you describe or consult with the patient, but is not well delineated because of existence of alcohol and tobacco use in these patients. So which is the factor? Exposure to the tobacco or really specific LPR as a reason. So actually there is a small study which has demonstrated, they studied the patients without smoking, without history of smoking or tobacco consumption and LPR, and they found lifetime non-smokers and non-drinkers, significant association between LPR and carcinoma of larynx. But this was very short study. But there is some correlation which people have been trying to associate with. There is 85% increase of LPRD with pre-malignant lesion. So there is a study which was done with one of my friend in Ampho Medical College. The patients with pre-malignant or malignant lesions would undergo the pH study, and 85% of them were found to have positive LPRD. So basically, there is a modest association between GRD, laryngeal cancer. They studied patients with laryngeal cancer and lung cancer, and then checked the incidence of LPR. So basically, they found it was more in laryngeal cancer patients. Again, this is just to correlate the association of LPR with laryngeal cancer. But there is no specification or specific data available between GRD and carcinoma in the specific laryngeal subsites. Okay, this is just not related, but if you want to have a precise incision removal without giving much of a trauma to the perichondrium or the vocal process, you can use robot. So this actually, I did one robotic removal of this arytenoid granuloma with a cold chill or this Caesar. This post-surgical. In summary, these are chronic inflammatory lesions seen in the posterior part of the vocal folds. LPR and trauma are main etiological factors. Treatment of LPR with voice therapy and surgical excision gives long-term results. Now, again to remember, if you see a patient of arytenoid granuloma, still there is no consensus for the origin or any etiological factor and definitive management of arytenoid granulomas, because we see many recurrences and long duration for their remission. If you want to really check yourself how much you know about the arachnoid granuloma, just go on to our website of Asia Pacific Laryngology Association.com. Go on to the quiz. Go on to the quiz section. There is a section on arachnoid granuloma, and you can take the quiz and check the score. If you want, there is a detailed information available on arachnoid granuloma there. And this is actually Mr. Vasant Oswal's contribution for all of us. These are the references, and I would like to really thank everybody for the patient hearing.
Thank you, Sachin. Thank you very much. In latter part of my career, LPR started making appearances as one of the causes of adenoid granuloma. And, as a rule of thumb, I would say that any pathology affecting the posterior half of the larynx, do consider LPR as a possibility. And the other question, of course, on laryngeal carcinoma is what comes first, a cart or a bull? See, this patient had long time LPR, but he came to you with carcinoma. Therefore, is there an association? I don't know. These are difficult questions. But now we go to Dr. Yalini Megneswaran, who is a GI and bariatric surgeon in Chicago. And one take-home message we would like to hear from Yalini is, when do we refer cases to you for those who are persistent or those who failed? Thank you very much, Dr. Yalini.
Yes, I just wanted to echo, thank you for inviting me to talk today. It's always great in these kind of multidisciplinary type of senses. And so as an esophageal surgeon, I'm really excited to be a part of this, learning a lot from our colleagues here, and hopefully I can share some of my experience. So I won't, spend too much time on what's already been hashed out here. I think part of this, my talk specifically is, considering that you treat the GERD in order to treat the LPR. And so, we've already talked a little bit about medical therapy. And so, we kind of see this a lot, especially in the US, patients just coming, just give me the quick fix, give me a medication that will fix my symptoms. And so, we know that the acid suppression really only palliates the symptoms and does not restore the function of the LES and treat the disease. And so, as we've already heard, GERD is more than acid reflux, right? So we have pepsin, bile, all these other gastric contents that are also coming up into the esophagus, and it's not really being treated with acid suppression. And so I'll talk briefly about the pathophysiology of GERD itself from a surgical standpoint and, kind of how I view the disease. I love talking about reflux, so I'll try to keep this as short as I can. But the pathology of GERD is essentially an incompetent lower esophageal sphincter. And we think about that in a lot of different ways. It's more complex, obviously, than a physical valve that's at the junction of the esophagus and stomach. There's multiple different muscles that probably contribute function, but most importantly is really understanding the anatomy of the esophagus, and that the lower and distal esophagus should be living in the pressurized abdomen, and goes through the small hole in the diaphragm, the hiatus. And so the intra-abdominal esophagus and the crural integrity are really crucial to the lower esophageal sphincter functioning properly. And we are learning more and more about this as esophageal surgeons, as we're evolving our techniques with anti-reflux surgery. This is a slide from actually Tom DeMeester that I really like in terms of showing that reflux is really, the degree of reflux is a degree of the LES failure and damage. And so there's multiple components that allow for the LES to be competent. And as we lose those different components of the LES, we see more and more severe GERD, which is seen with objectively with our Demeester score. And furthermore, these patients continue to progress their disease even on PPI therapy. And so this is well established as well, that on chronic PPIs, if patients have LES failure and chronic GERD, they're going to continue in this kind of cycle of progressing to non-erosive disease, to healable esophagitis, possibly back to non-erosive disease. But there is a significant amount of patients that will continue to progress to Barrett's esophagus and esophageal cancer. And so it's important to remember this, as you may be the first entry point of seeing these patients for their LPR symptoms, but they're really suffering from, GERD, which may, to this point of silent GERD, that likely needs to be treated or at least evaluated properly. And so I would argue that it's important, as you see these patients, to treat the LPR, but also treat the GERD, and keep that in mind, because esophageal cancer, if prevented or caught early, is much easier to treat than if later stages. And so when we talk about anti-reflux surgery and restoring the lower esophageal competency, there's a lot out there now in terms of what can be offered in terms of anti-reflux surgery. But regardless of, how the valve is reconstructed, all patients have a hiatal hernia that needs to be repaired. And that is part of the anti-reflux operation, restoring that distal esophagus, intra-abdominal, and reconstructing the crural diaphragm. And then there's this different variations on how we reconstruct the valve. I won't spend too much time on this, and I'm not sure what your esophageal surgeons are doing over there, but the traditional way we think about anti-reflux surgery is a Nissen fundoplication. And so this was developed, this paper is 1985, but this was developed in the 50s, 60s, this idea of fundoplication and 360-degree wrap around the esophagus. Obviously, there's always fear about referring patients for anti-reflux surgery because this is associated with side effects of bloating, or gas bloat, flatulence, dysphagia. And so a lot of us here who do a lot of anti-reflux surgery have actually moved to doing partial fundoplications. I send most of my patients home actually the same day when I do anti-reflux surgery. It's a very quick recovery. I actually don't wean PPIs post-op. My patients stop PPIs post-op. We have special techniques now, especially with robotic surgery, where we can make this very minimally invasive. The procedure is about 90 minutes. And I tell patients it's very similar to having your gallbladder out. And so I think with a lot of the advances now, anti-reflux surgery shouldn't be something that is thought of as a last resort or something that is quite morbid. So just briefly to talk about Nissen versus partial fundoplication, there's been many randomized controlled trials demonstrating that it's equally effective at controlling GERD and pH normalization with similar morbidity, but actually less dysphagia, less gas float, less flatulence. And so I almost exclusively do toupees or partial fundoplications for anti-reflux surgery because I do find that the data is compelling and patients do quite well. My conversation with patients is, if they're having PPI responsive disease, that the expectation is that 85 to 95% of patients will be able to completely stop all their acid suppression after surgery, go back to, having a quote unquote normal diet. Obviously, everything is within reason. When we look and talk specifically about extraesophageal reflux or LPR and those symptoms, it gets a little bit more complicated. I think we all know that surgery will have a better response than medical therapy. So this is the group out of Vanderbilt and their data. So I don't know if you can see all of this, but the top line here showing response to anti-reflux surgery. This top solid line is patients with typical heartburn symptoms that were responsive to acid suppression. So they're going to have the best response to anti-reflux surgery in terms of not having recurrence of their symptoms. The next line here is actually the dotted line here is the patients with heartburn who had non-responsive PPI disease. And then these other two lines, this very small dotted line here, hopefully you can see my arrow, and this, I don't know how to describe this other dotted line here, this bottom dotted line, are patients with extra esophageal symptoms. And so the higher one is when patients are PPI responsive or acid suppression responsive. They're going to obviously have a better response to reflux surgery than those that are not responsive. From the same group too, here we looked at, they looked at post-operative improvement of LPR symptoms, and if they had concurrent heartburn or regurgitation symptoms with high acid exposure on pH testing, they were more likely to have resolution of their symptoms. So when I offer these surgeries to patients, we have these real conversations about whether their symptoms are going to improve or not. But if they have objective evidence of GERD, I think it's always a good approach to take. And then lastly, this was a group, the same group that actually looked at endoscopic findings and improvement after surgery. The control group was PPIs or acid suppression therapy. And you can see that with surgery, there was a much greater improvement, if not total improvement, of these endoscopic findings compared to the control group on acid suppression, which shouldn't surprise. I don't think that surprises most of us here, but just good to have this data to share with patients. I won't spend much time on this. There obviously are other treatments that are happening for anti-reflux surgery. This is magnetic sphincter augmentation, or the LINX device you may have seen. There are contraindications for this. I don't routinely put this in. I usually, as a tertiary center, are often sent patients to take this out for various reasons. But, patients seem to do okay for the most part. There does appear to be normalization of the pH compared to acid suppression therapy, and improvement of symptoms. Again, another therapy that's come out is this transoral incisionless fundoplication. Originally, when it was first came out, it was this popularized thing. You don't need surgery. We can cure your reflux with an endoscopic procedure. They found that only 40% of patients had pH normalization. And really what we found was that without fixing the hiatal hernia surgically and really bringing that distal esophagus intra-abdominal, you weren't going to achieve restoration of the LES. And so now the company advocates that this is done concurrently with the surgery called a C-TIF or combined TIF, where you do a hiatal hernia repair surgically and then do the endoscopic fundoplication. I won't spend much time on that. I don't think I'm going to spend much time on this. We, at University of Chicago, we're doing a lot of new techniques to hopefully change, the way we think of anti-reflux surgery. We do a lot of robotics here. This is, a hiatal hernia repair I'm doing here, mobilizing the esophagus. You can see the crura there is open. And so this person has about a 3-centimeter hiatal hernia. And so I won't spend time here, but we do use a lot of different techniques intraoperatively to help restore the LES function. So here, this is the use of impedance planimetry, pre and post kind of the repair. You can see the restoration of the LES complex there. So who should have a surgical consultation who has LPR symptoms? I think, this scenario, a patient with Barrett's and a hiatal hernia, you should definitely send to see a surgeon for anti-reflux surgery. They obviously have had chronic GERD and now have metaplastic changes to their esophagus, can benefit from surgery. Somebody who has LPR esophagitis and is obese, has obesity, so BMI greater than 35 with comorbid conditions, or BMI greater than 40. A great anti-reflux operation for this patient is actually a gastric bypass that can treat their GERD, but also treat their obesity and comorbid conditions. BMI between 30 and 35 for GERD is a little bit controversial. Sometimes I do offer gastric bypass for those patients with central obesity, and I don't know what your recommendations are in India, but obviously of Asian descent, there is lower BMI thresholds we probably should be considering. Who should be, so I think everyone really should be offered a surgical consultation if you truly believe there's reflux. Any patient who wants to stop chronic PPI use and has objective evidence of GERD, any patient who has objective evidence of GERD and is non-responsive to PPI should be referred. And then really, really the patients that you should really consider referring are significant failure of the LES. So hiatal hernia greater than 3 centimeters, severe esophagitis, regurgitation, or Barrett's esophagus. And just want to leave you with this, you know, the likelihood of improvement with anti-reflux surgery is really going to be more successful with patients that have more distal reflux, large hiatal hernias, presence of typical symptoms, and depending on the severity of LPR. You know, there is some data that shows that even low Demeester scores with a Demeester of 9 could be high enough to cause significant LPR. And so it can be difficult sometimes to decide what's right for these patients, but I think having a good relationship with your esophageal surgeon always helps. So I'll leave it there for now.
Thank you very much, Dr. Yalini. I ask one question. My wife had macular hole surgery, and she was given a card to present it to any doctor that she is, because of anesthetic gases could cause problem there for some other reason if she had. So do you give a card after leg surgery to patients to produce it for possible MRI?
Yeah, they do. The company provides, they have a card that they keep with them that has their device number and kind of what other contraindications there are. We try to counsel patients pre-op. I don't do a lot of links. I only do it if patients request it. I don't really like to push it on patients because I think it's, what we are doing with fundoplication is still operation.
Yeah. I had a couple of MRIs, and they asked me about surgery on the eyes, metal here, pacemaker. They never asked me about links
About
device.
links.
That's
Yeah,
interesting.
it might be more common soon, but we'll see.
Yeah.
I've actually had to take some out for patients that needed MRI for cancer diagnoses later, who needed a higher Tesla MRI. And so that is one reason I've had to take them out before.
For those who don't know the news that there was in India, one of the hospitals, the whole wheelchair was sucked into MRI when the door was opened accidentally while MRI was in progress. You can imagine the strength of magnet that the MRI has.
Yeah.
Wonderful.
Yeah, I don't think you want to be going into an MRI with a links device.
So I think, thank you very much for your presentation. We have about 14 minutes, and I'd like to start with some questions which came to Dr. Gandhi from the audience, I think. And then if you've got any more questions from audience, we give them the preference for questions. So the first question from the audience is, the cases of globus pharyngeus are increasing day by day. The symptoms of LPR and N globus are sometimes confusing. Any guidelines? So please keep your answer briefly so that we can get as many questions as possible. So the question is, LPR, globus pharyngeus, what's a relationship? Anyone?
I can start with that. I think that for globus, I think it's important to really
Globus
distinguish whether or not
globus hystericus is what it means,
So persistent feeling that something is caught in the throat or that there's something that's stuck there. I think it's important, if you're trying to define it as LPR kind of being the cause of that, you really have to, as Ben mentioned in his presentation, have a good sense of whether or not the patient sort of meets at least a clinical suspicion of LPR. Do they have heartburn? Do they have other symptoms that would be consistent with LPR? Do they respond to, either anti-reflux therapy or / diet augmentation? If you've done a trial, at least an empiric trial of PPI, alginates, and diet modification, and there's no change in the globus sensation, then you have to start thinking about other things, I believe. And so while it's a very common complaint for a lot of us within ENT practices, I think it's important for us not to automatically ascribe it to LPR that's uncontrolled.
Okay, thank you. The next question is laryngopharyngeal disorder in children, can it increase the incidence of chronic rhinosinusitis? So that's for Bhavik.
There are studies out there which have shown a pretty deep correlation with both upper respiratory, that is rhinosinusitis, and otitis media and LPR. So yes, but then it's more of gaseous reflux, which tends to cause these CRS problems. The reflux, that is the acidic reflux, is less often so. But then in children with sinusitis, I don't think there are studies as yet. Adults, yes, but then in children, I don't think. Adenoids, yes, but sinusitis, I don't think I have come across a study which has shown that LPR and rhinosinusitis have
So
strong
it's
correlation.
it's a long shot. It's a long shot, yeah.
Long shot.
Not
So,
necessarily. Okay.
but then having said that, if they can be implicated in adenoids and tonsils, well, sinusitis is not too far away. So
Okay,
that's
okay. The next one is nocturnal cough sometimes associated with reflux disorder? Now, I don't know nocturnal cough is such a disease entity or not. I don't know. So who's going to tackle that? No?
So when I see patients who have a cough in the evening, I like to try to very carefully with the history differentiate, is the cough waking them up at night? Is the sleep apnea waking them up at night? Are they waking up at night anxious, coughing due to some sort of habit cough or a neurogenic cough? So we have lots of different situations, and certainly for the patient that lays down and immediately they start coughing and they're better when they're inclined, it's very suggestive, right? But it's one of the common reasons that we'll try an alginate at bedtime, 15 minutes before bedtime, and we'll try nighttime dosing of a PPI because it's fairly diagnostic, I think, and then we feel pretty secure about the diagnosis.
Thank you.
Yeah, I mean, I would comment
yeah,
too,
please.
it is helpful, when you can make that diagnosis, like you Ben was saying, with the alginate or PPI at night and the cough resolves. I operate on a lot of patients that actually their primary complaint is cough. It's difficult to counsel those patients before surgery, but I am often surprised how many patients have resolution of that symptom after surgery, and in fact actually report their sleep has been better than ever. And so I think it's an important one to really dive into.
Yeah, I came across somewhere I read that if you get a cough while you're lying down, more likely that you got GERD. And if you had cough while upright as well during daytime, then I think it's you also have LPR. Maybe it's reasonable to assume that. Yeah.
I think
Okay.
one of the precautions we tell these patients is to have a food well ahead of going to sleep, so maybe 3 to 4 hours. And number two is the position of the bed. So head should be up. I mean, you should be either pillows or maybe you should elevate the head end of the bed. Yeah.
Oh, very good. Now, have you any more questions from the audience, Dr. Andy? Have you got any more questions from the audience?
No,
No?
not
No.
none.
I'll make
Well-
one more point about the cough, recumbent cough. It's not uncommon for patients who have CRS, especially with substantial purulent postnasal drainage, that when they lie down, they actually get a lot more postnasal drainage to their larynx and it causes them to cough. So I always ask them if the cough is productive. And I do a bilateral nasal endoscopy on all cough patients that come to my clinic, in addition to the laryngoscopy, to rule out active CRS with drainage.
Okay, thank you. Now we'll go to some panel discussion. We got about 8 minutes. My own observation is that when I started ENT in 1960, that's some 63 years ago, the diagnosis and management of LPR did not exist. We didn't think about LPR at all. Or they were good, of course, not LPR. But we started thinking about LPR in 80s onwards and found a label, a convenient label for all those conditions such as spasmodic dysphonia, where a surgical strategy was not an option. So it may be a good label to put on if you don't have a firm diagnosis. How good it is, I'm not sure, but that leads us to a question of, is there a tendency of overdiagnosis of LPR amongst the ENT surgeons, particularly the younger generations? There is a lot of literature, a lot of on internet really, and it may be the fashion of the day, I'm not sure, but what do you think? Is there an overdiagnosis? Because a lot of people will have LPR, but they don't come to you because they don't have laryngeal symptoms to speak of. Or a lot of people
I'll
have
jump in.
GERD and they don't come to the doctor because they manage with it. So I don't know, every time a patient comes with the laryngeal problem, whatever it is, do you actually say that he has got LPR as well? That's overdiagnosis.
Yeah. I think that there is a trend, at least historically, to use that as a catch-all diagnosis when we don't understand what's going on. And I think as time has gone on and time has shown, our ability to diagnose it as otolaryngologists is somewhat limited. So I think that there's kind of a push back in the other direction of not necessarily chalking everything that we see, in terms of symptoms up to LPR as a diagnosis. So I think maybe those that trained in the 80s or 90s, maybe, and I can't speak for them, predisposed to thinking, oh, this might be LPR. But I think the generation that's come along now since is trained in the 2000s, 2010s, might be thinking that there might be other things going on. But I think it is over.
Okay. Can I put all of you on the spot, please? On spot, yeah. So what is your give me 3 conditions in the larynx that you would suspect, your gold standard, that is LPR, proven or not proven? Go on, Brandon.
For me, it depends on symptoms. So, even if I look at laryngoscopy, and that's what you're referring to, a flexible laryngoscopy, if I see post-cricoid edema, if I see intrarytenoid hyperplasia, if I see a significant erythema of the posterior part of the cords, I'm thinking of LPR and reflux, but I always kind of qualify that in the setting of the patient's symptoms. So I don't want to say that I can diagnose reflux based on the laryngoscopy alone. Ben, what do you think?
I'm asking that question because a lot of our audience don't have the facility to do investigations for LPR or anything else, and they are in private practice and all that. And we need to tell them that these are my gold standard symptoms and findings that I say put on LPR treatment as well. So, Ben?
Yeah, I think it's a great question. You talk about the people that are walking around, they're not coming to the clinic with these symptoms, but they have them. So then the question is, why is the globus or the mucus bothering this patient so much? I mean, why don't they just swallow it, right? Why don't they just take a sip of water and move on with their day? So there is a continuum, right? But the continuum may stop if you think that LPR is a pre-malignant condition, and that any degree of LPR needs to be, controlled aggressively to prevent long-term complications like cancer or something like that. So, I think it's interesting, right? Because at the moment that you see the patient, you can say, okay, get an upper endoscopy. Let's do a T&E. Let's send you to GI, barium esophagram, maybe a little hiatal hernia. Okay, does that need to be treated, right? Not a huge paraesophageal one, but and then, maybe they don't, but everything looks good and it's clear at the moment. How aggressively do we need to treat them? But I think currently, with the focus on healthy eating, healthy lifestyle, diet modification, maybe using alginates, we can be a little bit what's the word?
Conservative?
We can be a little bit loose in saying, oh yeah, you know, lose a little weight, stop smoking, avoid caffeine. Like I don't mind doing that, right? Because if the patient gets better, then great, and then there are other things that are going to benefit them, but I'm less likely to be loose with prescribing a PPI.
We got 2 minutes left now. One of the things that we see in England is health visitors see a lot of this stuff on social media. And when they go to healthcare workers go to patients at home or whatever, and there's a little baby, 5-month-old, and she's got burping and everything else. She says, oh, she must go to a doctor and get LPR treatment, because that's what, or gut treatment. So social media has caused a lot of referrals to our primary physicians, and primary physicians said that we must prescribe. If we don't give a pill, we'll be sued. So there may be some part of our, I think I read somewhere there is some many billion-dollar industry LPR medication has come to it. So maybe overprescription, maybe overdiagnosis, I'm not sure. Now we have 1 minute left, and I would leave Sachin Gandhi to tell us about the next episode in this classical series, I must say, most enjoyable, most informative series that you created. Sachin. It's the 9th of February, I think, is it? The next one. No?
Yeah, it's 17th of
No.
February.
Sorry, what date?
17th of February.
Hmm.
And the topic would be sulcus vocalis and emerging therapeutic options for loss of superficial lamina propria.
Okay, and you will circulate that, yeah?
Topic, but we see these patients, I mean, like LPR, there is a tendency to diagnose now more and more cases of sulcus vocalis and inadequate glottic closure. So I think with the vocal strain and industry and diagnostic tools, maybe many people doing video laryngoscopy. Now I am started getting many referrals as sulcus vocalis. But again, like LPR, there is no consensus. There is no definitive management protocols and difficult to treat thing. I think we will have some new trends and discussion on pathophysiology management.
Thank you very much. Can I really thank absolutely sincerely for all our faculty for putting their time and effort and experience to our audience. It's been one of the controversial topics. There's a hell of a lot about it, and it's not easy to pinpoint and give some yes or no answers in this era. Maybe we'll arrive there somewhere. Artificial intelligence might help us there. Hope so. Okay. Thank you very much. Thank you all.
Just to add, Mr. Oswal, I think as I see, there are more than 800 registrations and live attendance is more than 700. I think I would like to thank all these participants and making this more enriching for everybody.
So can you send us can you send us the breakdown of countrywide and also how many people? Because I think it's very useful.
Yes,
thank you very much, Sachin.
Thank you. Thank you all.
Thank you, Bhavik. Thank you,
Ben. Thank you.
Thank you, Ben. And thank you, Alini.